And we're live in 5,
4, 3, 2, 1.
Hi, everyone. This is John Mangan. I'm one of the spine surgeons at Roth Orthopedics. Thank you for joining us tonight for our Young Surgeons Conference. It's my pleasure to introduce my partner and my colleague, Chris Kepler, who is an associate professor of orthopedic surgery here at Thomas Jefferson University Hospital, who runs our basic science lab here at Rothman, working on all of our animal models for science and spine surgery. Without further ado, Dr. Kepler.
Thank you, John. I'd like to thank the Seattle Science Foundation for having us. This is at once sort of a high moment in my career and a low moment in my career. And it's a high moment because I love SSF and it's always been fun being on the webinars. It's a low moment because the second that the advertising campaign for this session hit the internet, I got like 25 text messages that pointed out one of two things. One, that I'm not young. And two, that the picture they're showing of me has a lot less gray in my beard. So, this is not a total win, but I'll still take it because I'm glad to participate with these guys. And really, this came about, the reason I'm even here is because I'm not young. These are younger surgeons in their first year of practice, and they needed what they were told they needed an older guy to be the mentor, and they immediately thought of me. So I guess I'm flattered with backhanded compliment. I'm going to share my screen. This is mostly about these guys' clinical talks about things that we all wish we had known when we started practice. I have a couple slides which are more practical advice, really, about things I'd known when I started practice. I have disclosures which are not relevant to this talk. So first point is haters are going to hate. And you need to go into practice with as thick a skin as you can muster and fake it until you make it. Almost no matter where you work, you'll be competition for other spine surgeons who are already in practice. They're going to hate on you. They're going to talk about you to the staff. They're going to talk about you to, if you share residents, and that stuff's going to happen. And you got to know it's going to happen. And it's not you. It's never going to be you. And so you got to try to ignore that the best you can. So there's nothing really you can do about that except for not talk back and try to take the high road as long as you can. And at some point you'll feel like you've earned it and you can talk back, but if start in practice, get along to get along. Number two, you're not that good of a surgeon yet. And so again, get thick skin. Things that seemed easy to you during your fellowship aren't always that easy on your own. It's a different feeling when things start going south, when you're the one who has to fix it. And you're the one who's going to have to talk to the family and think of what you're going to say and talk to the patient and think of what you're going to say. And so there are definitely days when you leave the hospital feeling like you did more harm than good. There's days that spine surgery sucks, but you got to push through it. And there's always a bright light at the end of the tunnel. It just sometimes takes a little bit of doing to get there. Number three, you're not that fast of a surgeon. The same thing, get thick skin. A lot of times I think the appearance of being fast when you're just starting practice isn't really about actually being fast. It's about trying to book a mix of cases so that you're not doing, only revision surgery or revision fusions in the lumbar spine on one day. And you have a gimme so that you can seem like you're in and out. And even if you have one hard case, it's not all hard cases. So getting through cases without complications is the secret to appearing fast. And Dr. Vaquero always, tells us at the beginning, like, you won't be fast for 5 years, so don't try. And there are surgeons who at 5 years will be fast and surgeons who won't be fast, but trying to be fast isn't usually a way to do it. Trying to be safe is the way to be fast. Fewer cases, tight indications. This is the way that you build a practice. One patient who gets on, especially in this day of, sort of instantaneous access through social media, one patient who tells everybody in their network, their friends and their family, these suck, hurts a lot more and does a lot more damage to your practice than the good you get from one person telling everybody they know that you're great. And there is an obvious benefit for telling them you're great, but the negative hurts a lot more. No one's going to take a chance on a surgeon that they read somewhere isn't good. And so, being careful and choosing your cases very well and trying to, stack the deck a little bit in your favor is to your advantage, especially when you're starting. It's still to my advantage. But it's more to your advantage when you're starting because you don't have that population of patients who have done well, who are out there spreading the good word. Ask for help. Despite everybody hating you, who's competing with you, asking for help, even if it's outside your practice, ingratiates you to other surgeons. It shows that you respect them. There's a signal to deference that you need their help or you would like their help to complete a difficult case, and it helps you build a team that'll help you, for that case, but also help you down the road and can bring that person to your side, even if they see you as a competitor in some way. They'll have a better feeling towards you, and certainly even just from the standpoint of like other surgeons in the area seeing your second opinions or seeing patients after things don't go well, that I think that helps you in the long run. If you can do hard cases with other surgeons, that's great. That's a little bit practice dependent and environment dependent. But even if you have to go outside your practice, I think that is something that helps you build the team, it builds your practice, and also keeps you a little bit safer when you have cases that are somewhat outside of your comfort zone. Ask for help. Lean on your fellowship mentors, lean on your residency mentors. The only spine surgeons who don't talk about complications or say they haven't had them are liars. Like every single person top to bottom has been in the same shitty spot that you're in, has had the same problems. And, you can leverage their experience. And sometimes it comes from places that you wouldn't expect it. But I think that, being embarrassed about it and keeping it to yourself in the spine surgery community isn't really a win. I think that's a way to lose and sometimes to compound your own mistakes just because you don't have the experience on how to get out of a tricky spot. And so, with sort of that, philosophizing and standing on the soapbox aside, we'll get on to the clinical advice. There's 3 talks, one after another. We're going to save questions for the end. The first is JP Warner, who's going to talk about perioperative bone health, which is like that thing you should have learned in residency and, maybe never did. I didn't. Justin Stull is going to talk about autoimmune disease and DMARDs, and John Mangan, who you already heard from, but is going to talk about managing anticoagulation in the periop period. So I'm going to turn it over to JP.
All right, thank you very much, Dr. Kepler. So I'm going to be talking about perioperative bone health. My name is JP Warner. I'm an orthopedic surgeon at the Medical College of Wisconsin. Okay, so just a brief overview. I'm going to be talking about osteoporosis, prevalence, definition, how to diagnose it, and then some of the impacts it has. We're going to talk about screening in spine surgery and how to do that. And then perioperative management strategies, specifically some of the pharmacologic treatments that you can offer patients. And then we're going to look at an algorithm by Dr. Paul Anderson out of the University of Wisconsin. It's in a recent JBJS article, and I think it mirrors what I do in practice pretty well. So osteoporosis, it's known to affect over 200 million people worldwide. One study found that 20% of all patients undergoing spine surgery had osteoporosis, and up to 50% of women greater than 50 years of age have osteoporosis. Again, that article by Dr. Paul Anderson showed that 124 patients who are undergoing either elective spine or arthroplasty surgery, 91% of them actually met the National Osteoporosis Foundation criteria for osteoporosis. And so we'll talk about exactly what that means. From a definition standpoint, so it's just a bone mineral density of less than 2.5 standard deviations below the mean of a young healthy control. So that's by definition your T-score. It's characterized by diminished bone mass and microarchitectural disruptions of both trabecular and cortical bone. There's 2 different types. There's primary and secondary. So primary is the one that everybody thinks about when you think of osteoporosis. This is your postmenopausal woman due to estrogen deficiency. Type 2s are going to be secondary causes. So it's going to be age-related and it impacts both men and women, although it does still have a preference towards women. And it's usually due to an underlying condition like kidney disease, vitamin D deficiency, medications like steroids, PPIs, things like that. From an economic impact standpoint, there are huge costs to the healthcare system. We know the baby boomer generation is getting older and starting to enter into this arena. And so these costs are going to continue to increase. And so there's 81.5 billion in direct and 95.2 in indirect costs by 2040. These numbers are only reflecting fracture related costs. So all the complications and revisions due to poor bone quality from surgery aren't even included in these numbers. And again, some of those complications are going to include subsidence, adjacent segment degeneration, PJK or F, intraoperative fractures, screw loosening, screw pullout, things of that nature. This is one of my favorite articles. It surveyed orthopedic surgeons. Over 60% of them reported that low bone mineral density would be grounds to alter their operative strategy. Only 4% of them actually quantitated any kind of bone mineral density. So to me, that kind of says what a lot of people think, which is, keep calm, put your blinders on, things will be fine, just work through it. If you do that with osteoporosis in some of these patients, you can get into some big problems. Thankfully, these are not my cases, but probably just because I haven't been practicing long enough to see them in follow-up. But especially for something like deformity surgery, osteoporosis is one of those modifiable risk factors. There's so many different things that can go wrong from a technical standpoint in surgery that if there's something that you can modify, you should definitely do that before surgery. Okay, so how do you identify these people? So the World Health Organization and the NOF have two different definitions. So, or at least patients that qualify for osteoporotic pharmacologic treatment. So the World Health Organization says that anybody who's a postmenopausal woman or any man above 50 years of age should get osteoporosis screening. They do that with a DEXA scan or a bone density scan. The definition of normal bone density is anything, a T-score of greater than -1. Osteopenia is between -2.5 and 1. And then osteoporosis is anything less than 2.5 standard deviations below that. So that T-score of less than 2.5. The National Osteoporosis Foundation. So this is the one that you kind of have to be aware of. So not only is it less than 2.5 definition for osteoporosis, but people will meet criteria and their insurances will pay for pharmacologic treatment if they have a T-score of less than 2.4 or 1.1. So that's osteopenia by definition of the World Health Organization. But if those same patients have a FRAX index of greater than 20% of a major osteoporotic fracture or greater than 3% of a hip fracture, they actually will qualify for osteoporotic treatment. And so these are a lot of patients, their T-score seems, again, osteopenic, they may not qualify. You can still get them treatment before you do surgery if you calculate this FRAX index, and we'll look at what that is in a second here. And then kind of the poor man's version of that is just CT scans. You can look at Hounsfield units, any kind of imaging software calculates this for you easily. Less than 130 is going to be osteopenia. Less than 100 is usually osteoporosis. This is one of those calculators that's online of the FRAX index. So the initial portion of it is just some demographic information. And then there's a series of seven simple questions that you can ask your patients. If they've had a previous fracture, if their parents have had a hip fracture, if they are a known smoker, they take steroids, have RA, any kind of secondary osteoporosis, or if they drink more than 3 drinks per day. And then you can enter in what their T-score is. So again, even if they're osteopenic, if these FRAX scores are high enough, they'll still qualify for treatment. And so it'll then calculate what your major osteoporotic fracture risk is. And if that's greater than 20%, they qualify. Hip fracture less than 3% or greater than 3%, and they'll qualify for treatment. So once you've identified who is osteoporotic or osteopenic and may or may not qualify for treatment, you can then start to manage these patients. So vitamin D levels are easy to obtain, 25 hydroxyvitamin D. Less than 30 is inadequacy, less than 20 defines deficiency. If they're deficient, usually there's a loading dose. You can talk to your bone health clinic, and usually that's somewhere between 20 to 50,000 units per day. Even if they have completely normal levels, you can still, there's still the recommendation to give them at least 1,000 units per day. So I basically start and make sure that everybody that I'm going to operate on, especially my fusion patients, are on vitamin D and calcium. Calcium per day is usually about 1,200 milligrams. And that's, again, in anybody who's a woman who's greater than 51 or a man greater than 71 years. So there's a few different, if they are osteoporotic or penic with a high FRAX index, they can then get or qualify for therapy. They can do estrogen replacement therapy. So this is just going to be basically giving them estrogen to create or enhance the estrogenic response in bone tissues. However, it's a known risk factor for DVT and PE, so I never do this for my patients. Calcitonin regulates calcium by altering renal intestinal absorption, modulates osteoblastic and clastic activity, but again is associated with the increased risk of any malignancy, and that's put out by the FDA. So never ever use that for my patients either. Bisphosphonates are typically what everybody thinks of when you think of osteoporosis treatment. These are anti-resorptive drugs that slow bone remodeling. They're usually the first line for osteoporosis management, or at least have been historically. There's multiple trials out there. So initially, people were concerned that since they're inhibiting osteoclastic activity, that they may in some way hurt fusion rates. And so there's multiple studies that show that that's not actually the case. So if they're on a bisphosphonate, you can continue that through even fusion surgery. Denosumab is a human IgG antibody. It binds rank ligand, keeps it from binding rank on osteoclasts, which then would inhibit bone resorption and improve your bone density. This in combination with teriparatide, which is Forteo, has been shown to be more effective than it by itself. So teriparatide or Forteo, Tymlos, these are all anabolic agents that promote bone formation. So these are different than just inhibiting osteoclastic activity. These actually build back bone. So I think a lot of surgeons typically like these when they're evaluating and trying to treat their potentially operative patients. There was also a meta-analysis of Forteo. It showed improved bone mineral density and increased bone mass, as well as improvement in time to fusion if you do it weekly. So kind of these spurt once a week doses for 6 months. The drug that I've actually used for most of my patients now is Ramosumab. So I work closely with our bone health clinic, and I try to get my patients on this. This is Avinity is the trade name. It's a monoclonal antibody against sclerostin. So sclerostin inhibits the Wnt and BMP pathways and impedes osteoblast proliferation and decreases bone formation. And so if you inhibit sclerostin, you actually reverse this and you can build back bone. And then it also has an anti-osteoclastic property as well. So it kind of does what both Forteo and Denosumab do in combination by itself. Sclerostin is found only in bone tissue, so it has a fairly targeted effect on where you want it. And then one of the biggest reasons that I like it and I really push for my patients to have it is that there's a couple articles out of the New England Journal of Medicine that look at bone formation markers, specifically this P1NP. And within 14 days, it actually peaks on Ramosumab or Avinity. And so if you have a call patient who you can't or don't really have a choice to operate on, or you get in there and the bone quality is really, really poor, even after surgery, you're going to get peak levels of bone formation markers really, really quickly in this drug. And so I think that this is a great one to use if you can get your patient on it. These are those graphs from the New England Journal of Medicine showing that there's definitely improvements in bone mineral density at the lumbar spine, total hip, hip, and then also the femoral neck against placebos. And then to the right, you see the graph of the P1NP, and you see that huge osteoblastic activity within the first 14 days of being on the medication. So again, this is the one that I really push for my patients to get. This is the algorithm by Dr. Anderson in the JBJS article. This kind of puts it all together and is actually very close to what I do for my patients. So I take a really good history, look if there's any kind of height loss, what their fracture history is. Obviously, if they have a DEXA scan, you can look for their T-score. And then I essentially start anybody who I'm thinking about surgery on both vitamin D and calcium at that time. If they have a known T-score that qualifies for treatment, or if they don't have one and then I get a DEXA scan and they do, they'll kind of go down this abnormal pathway. If they have a normal one, they'll go and proceed right to surgery. If it's abnormal, usually they go directly into my the bone health clinic in my institution, and then they'll kind of continue that workup with calcium, creatinine, vitamin D levels, PTH. But these are easy to get even if you don't have a bone health clinic. And then they'll make that assessment, see if their insurance will qualify for, or if they qualify for insurance coverage of pharmacologic treatment. And if they do, they start that. 3 months is the typical time window, that anabolic window for anabolic agents. And so if you're doing Forteo, Tymlos, or Avinity, waiting the 3 months is ideal. Again, Avinity has that peak earlier than any of them. And so if you're really pressed for time, I think that's probably the best one to start patients on. And then if you're doing just an anti-osteoclastic one, so some of the bisphosphonates, they typically recommend at least 6 months to prolong surgery if possible. These are just my references for the talk, and thank you for your time.
Great, JP. That was awesome. Thank you for your talk. That was super enlightening, and I definitely took a couple pearls from that I'll steal from you. Dr. Kepler, thanks for the pep talk. I feel great about myself right now. No, but in all seriousness, those insights were very valuable. So thank you. My name is Justin Stull. I'm going to be talking about rheumatoid, DMARDs, and how we approach their application around spine surgery. I'm an associate at Rothman in the greater New York region. So this is me. It's a little bit of my background there. This is just going to be a brief talk kind of going over what we know and more specifically what we don't know. So I'll be talking about autoimmune diseases and rheumatoid specifically, talking about DMARDs, their success with treating rheumatoid and their concerns around surgery, and then just kind of give you a little bit of taste of what's on the horizon for DMARD therapy. So autoimmune diseases were dubbed horror autotoxicus in the late 19th century as medical investigation kind of dug into their cause. This is dysregulation of antibodies or T cells against the host, the genetics of which seem to be in the form of T cell receptors, immunoglobulins, and MHCs that target cell production and proteins and protein synthesis. These dysregulations result in tissue damage. And obviously, this is an evolving understanding of the disease, and as such, an evolving therapeutic and treatment for the diseases of autoimmunity. Specifically, with regard to the spine and autoimmune disease, I'll be focusing on RA. Rheumatoid arthritis targets small joints greater than large joints. We, at least myself, typically think of RA in the cervical spine, and especially the high cervical spine. It's brought on by chronic inflammation in the synovium. Macrophages release TNF-alpha, creating this inflammatory environment and tissue destruction. About 80% of patients with rheumatoid have positive rheumatoid factor. It affects women more than men. Like I said, small joints more than large joints. And from a historical perspective, at least, 86% of rheumatoid patients present with, or at some point will have cervical pathology on X-ray. 10% of those patients will develop neurological symptoms. So again, kind of focusing on the images that I have here, atlantoaxial instability, increased ADI with flexion from extension on X-rays, and odontoid pannus formation on MRI are pretty standard findings, at least from a historical perspective with regard to rheumatoid. But please don't forget about subluxation in the subaxial cervical spine due to facet joint damage and the repercussions of that disease. TNF-alpha, as mentioned, is a major contributor to the tissue destruction as a result of rheumatoid. Tumor necrosis factor alpha is a pro-inflammatory cytokine activated by macrophages that induces an inflammatory response and eventually synovial soft tissue damage. Fortunately, we've been able to identify TNF-alpha and use it as a target for successful treatment through DMARD therapy. So disease-modifying anti-rheumatic drugs as a drug class that's aimed at the anti-immune disorders and specifically the inflammatory arthritises. Traditionally, these were more focused on affecting cell reproduction, protein synthesis, the methotrexates and hydroxychloroquines, which became popular in the 1990s. But more recently, the 2000s, the last 20 years, we've been using biologics targeting these different cytokines and the pathways that produce them. You'll see a couple familiar names here: Enbrel, Humira, maybe Xeljanz, Rinvoq, and if not, we'll kind of touch on these at the end. And we've used these drugs with great success. These graphs here show the volume of surgery, both suboccipital procedures here at the top and then posterior cervical procedures at the bottom. And what they show is that the squares represent total volume, whereas the circles represent RA patients. And so what you'll notice is that there's an increase in overall spine procedures being done, but no volume increase in RA patients, which indicates that we're treating them at least successfully to some degree, as the number is not increasing with the overall number of spine surgeries being completed. So there's actually a decreasing percentage in terms of the relative population that's undergoing surgery. Despite the successes with the DMARD therapy, there is a concern about using DMARDs as it relates to the operating room and going to surgery. And so these are guidelines that were developed and released in 2017 and then updated in 2022 by the American College of Rheumatology in combination with the American Association of Hip and Knee Surgeons. So you'll see here that some DMARDs are recommended to continue. These are more of the traditional type drugs, as well as those aimed at treating severe lupus conditions. And these can be continued through the time of surgery. On the other hand, most of the biologics which are being used now and used extensively are recommended to be discontinued in the joints literature specifically. You'll notice there's a range for how long to discontinue these medications, whether it's weeks with some of the more traditional ones, Humira, or days for those in JAK inhibitors that we were discussing. All that being said, these recommendations are based on low quality evidence, or low level evidence rather. There's just not a lot out there. And it seems to the joints guys that this was what makes the most sense to avoid the catastrophe of having an infection. But there's not a lot to support these recommendations. In the general ortho literature, this is a recent systematic review that included 11 studies, over 7,000 patients, 2/3 of which continued their meds, and 1/3 that continued their medications and 2/3 that didn't. This includes spine surgery amongst other procedures, trauma, some plastic surgery, but there was no significant difference in surgical site infection or wound healing. The only significant difference that was noticed were the increase in rheumatoid flares in those that discontinued their medications. And those patients with flares ended up needing steroid treatments most of the time, inpatient stays, and so it was not an insignificant burden. Moving to spine-specific literature for the rest of the talk, this is a recent systematic review that included 9 studies, 700 rheumatoid patients, 2,500 non-RA patients. The rheumatoid patients had an increased relative risk of surgical site infection, increased odds of complications, implant-related complications, and reoperation. I thought that this was an excellent study, but I would say that the literature is heterogeneous. Some of it is old, and almost all of it's underpowered just by the nature of the group we're studying. This is another example of a study that did the best with what was available. High rates of surgical site infection and wound healing among those patients continuing DMARD therapies. It does appear that there may be an impact on fusion rates, although there's not a lot of literature out there with that specifically in mind. Recent retrospective review from the Cleveland Clinic. So this study looked at TNF-alpha inhibitors versus other DMARDs versus controls of patients not on DMARD medications. There was a great amount of heterogeneity in when the patients came off of their meds, when they did. And basically what it showed was there's about 20% of reoperation for those patients taking TNF-alphas. Half of that was for infection. The other half was for adjacent segment or fusion failure. The reoperation rate was about 10% in those on other DMARDs and just over 5% in the control group. One last multi-center retrospective review to cover here. This was specifically evaluating RA patients and DMARD therapy with regard to OC fusions or C1-2 fusions. And the long and the short of it is not a lot of patients. Again, only 19 who continued their meds and 20 who discontinued. But what they showed was there were only one infection in the group that continued their med versus 2 that discontinued. Of the revision surgeries that were done, most were not for infection or wound healing. There was adjacent segment and pseudoarthrosis. So there were some issues with fusion overall. And again, I want to point out the patients who discontinued their med had RA flares, which required hospital admission, resumption of the DMARDs, as well as steroid therapy. So I think that this consensus paper from the ICM back in 2018, with which you'll notice Chris Kepler is an author, and I'll quote it because I feel that this summarizes the data well, even at the current time. The optimal strategy for managing DMARD medications during the perioperative period of spine surgery is unknown due to the lack of evidence and largely based on low quality evidence and expert opinion. We recommend that a rheumatologist be involved in the medication management around the time of surgery. And that's what I do. These are individual patients with a spectrum of disease and disease severity. And I think that it's important to approach each one as an individual, especially since we don't have great guiding literature at this point. I do just want to touch on the JAK inhibitors real quick. My sister's actually a rheumatologist, and she seems pretty excited about the potential of these drugs, which is why I wanted to highlight it. This targets the JAK-STAT pathway, which is very specific, but involved in the production of a bunch of different cytokines. This seems to be better tolerated as a long-term therapy versus other biologics because of the lack of side effects, because it's so specifically targeted. Similar cost, similar infection rates, but it also might be better at controlling pain because it decreases IL-6 production. And then lastly, specifically with Rinvoq, which is one of these JAK inhibitors, there seems to be less progression of radiographic disease as compared to traditional DMARDs, as well as other JAK inhibitors. So I wanted to highlight that, and then just kind of make a plea for anybody that's in a position to do research focused on this. We really do need more evidence and more studies focusing on what the best thing to do around DMARD therapy and spine surgery is. But in the meantime, we got to work with our rheumatology colleagues and treat each individual individually. So with that, I will turn it over to John Mangan. Thank you all very much.
Thanks, Justin. That was great. Definitely something that comes up in my practice that I always wonder about is what's the optimum treatment for these patients. So that was great. Thank you very much. And then let me just pull this up here. So I'm John Mangan. It's nice to meet everybody out there. Thank you for joining us tonight. I'm going to be talking about anticoagulation in spine surgery. So just a little bit of an overview. Today, we're going to talk about preoperative considerations. I'll briefly go over some of the common medications that we see, and then we'll talk about perioperative management of anticoagulants in spine surgery. So I think when we talk about anticoagulation around spine surgery, we're really talking about two different things. So first is, how do we manage patients that are on chronic anticoagulation? And the second is, how do we manage the risk of venous thromboembolism around the time of surgery? So to start, let's talk about preoperative considerations. I think it's important for all of us to know, what medications our patients are on preoperatively. This includes nonsteroidal anti-inflammatory medications, anticoagulants, and supplements. And this can be a challenge for surgeons to really get a good understanding of what patients are taking, as not all over-the-counter medications and supplements are reported in the electronic medical record. So it does take actually asking patients, what are you taking on a daily basis? Because some medications, such as supplements, may affect their bleeding time and bleeding around surgery. So it's important to know how to manage all of those things. It's important to know when patients are on anticoagulants, why are they on it? Is it for atrial fibrillation? Is it because they have a cardiac valve? And it's important to know who manages it, if it's their primary care doctor or cardiologist or vascular medicine. So this is a great study and a great resource for everybody out there. This is the guidelines for interventional spine procedures. This is by the American Society of Regional Anesthesia. This is a very comprehensive review that goes through most of the common medications and over-the-counter drugs and supplements that our patients take. And they've really done a nice job of summarizing the literature as it relates to interventional spine procedures. And they have kind of clear guidelines as to when to stop these medications before the procedures, and in some cases, when to restart them afterwards. And a lot of the work done in spine surgery kind of bases their recommendations or their suggestions, I should say, off of this literature. So when we're talking about preoperative considerations, I thought I would just touch base on a few select medications that I think most of us probably interact with on a fairly frequent basis that our patients are on. So aspirin is a drug that, a significant number of my patients are on. And the mechanism of aspirin is that it irreversibly is going to block COX-1 and COX-2. It has a half-life of only 20 minutes. The interesting thing about aspirin is that when it irreversibly inhibits COX-1, all of the platelets affected by that are unable to have their normal aggregation ability until that platelet turns over. And it takes about 10 days for each platelet to turn over that's affected by aspirin. So for patients that don't have any significant cardiac history, the relative recommendation, if you will, to stop aspirin before surgery is somewhere between 10 and 14 days, and it varies based on the literature. There is some literature that supports continuing aspirin throughout the perioperative period. And the ICM that Justin referenced earlier, looking at VTE, they recommend in patients with a significant cardiac history that it may be reasonable to stop aspirin up to 3 days ahead of surgery rather than 10 days. Clopidogrel is another antiplatelet. It's a P2Y12 inhibitor. It has a half-life of 6 hours. And the general recommendation for Plavix is that you hold it 7 days before surgery. Low molecular weight heparin or enoxaparin or Lovenox, that's going to bind antithrombin 3, which will inhibit thrombin. It has a half-life of 7 hours. We typically in the hospital will see it in 2 different doses. There's a prophylactic dose that a lot of our trauma patients may be on. And it's reasonable to proceed with surgery 12 hours after the last dose. But for patients that are on therapeutic doses, which is a weight-based dose, it may be more reasonable to wait 24 hours or more after that last dose. Warfarin is still something that we see pretty frequently despite newer drugs that are available. This is a vitamin K antagonist. It has a half-life of 20 hours to 60 hours. Recommendation is that you want to stop it usually about 5 days ahead of surgery, and you really want to let their INR drift to normal, so you want it to be less than 1.2. Some surgeons are happy to operate on a slightly higher INR, but in general, less than 1.2 is ideal. The last 2 medications are direct 10A inhibitors. So this is apixaban and Xarelto or rivaroxaban. For apixaban, the half-life, which is important in these drugs, is somewhere between 6 and 12 hours. And in rivaroxaban, it's somewhere between 5 and 9 hours. Really, the recommendations are to reduce their pharmacokinetic profile by 5 half-lives before you proceed with surgery. So typically for most of these drugs in this class, it's somewhere between 3 days. I think most of us probably hold them slightly longer if it's acceptable to their cardiologist or prescriber, depending on what their perioperative risk is. So I mentioned it before, but there was the international consensus meeting on thrombotic embolisms, and that was back in 2018. This was published in JBJS in 2022. And they sought to answer the question, in patients that are on anticoagulants for non-spinal disorders, is perioperative bridging therapy necessary following cessation of anticoagulation prior to spine surgery? And this is something I think that comes up for all of us. And, are our patients going to be bridged or not going to be bridged? I think most of us defer to their cardiologist or whoever their prescriber is. But I think it's important for all of us to know, what is the recommendation or what does the literature say about bridging? And I think, the point that the recommendation from the meeting is that, when comparing bridging to placebo, there really was no difference in the risk of VTE in patients undergoing spine surgery, whether they were bridged or not. And those that were bridged had a much higher risk of having a major bleeding event. However, there's some patients that are very high risk and they're going to require bridging, and you should leave that up to the discretion of their treating physician, obviously with input from your surgical opinion. I thought this was important too. So this is, what does the cardiology literature say about bridging for patients? So this is the use and outcomes associated with bridging during anticoagulation interruptions in patients with AFib. This is part of the outcomes registry for better informed treatment of AFib. This was published in Circulation. And what they found was that a quarter of patients that have their anticoagulation interrupted are bridged, and those that are bridged have a higher risk of having bleeding and adverse events. So they don't support the use of bridging in their current practices. Other medications that we commonly see, non-steroidal anti-inflammatory medications. So NSAIDs, most of our patients are on these at some point before surgery. So there's a concern over inhibition, again, of COX-1 that leads to the same platelet dysfunction, similar to aspirin, and that can increase bleeding perioperatively. There's recommendations for holding NSAIDs that vary anywhere from 7 to 14 days. If you look at the reference that I had earlier at the ASRA, they really go through each of the common non-steroidal anti-inflammatory medications and do a good overview of which drugs require, what length before surgery. But I think as a blanket statement, most of us try to hold these medications somewhere between 7 and 14 days before surgery. Next is probably one that most people don't think about is SSRIs, or serotonin reuptake inhibitors. So what they do is they actually affect the same serotonin reuptake mechanism in platelets. And what that does is it prevents them from taking serotonin up from in the blood, which decreases platelet aggregation and actually can lead to increased bleeding. We don't typically stop these medications in the perioperative period due to concerns of complications from stopping these acutely. But it's important to know that patients on these medications may have more bleeding at the time of surgery. Lastly here, I just briefly listed a few supplements that can lead to abnormal bleeding at the time of surgery. There's many more that I haven't listed here, so it's important to kind of have an idea what these supplements are and if your patients are taking them. Next, we're going to talk about the perioperative period and how it relates to anticoagulation. So I think one common controversy or question that comes up is how do we manage VTE risk in spine surgery? This is a well-known complication associated with orthopedic and spine surgeries. The risk of having a venous thrombotic event around the time of surgery really varies in the literature from 0.3% to 31%. The risk of having a pulmonary embolism after spine surgery has been estimated to be somewhere around 1.38%. And there's a relatively low, but not negligible risk of having a fatal pulmonary embolism after spine surgery, which is somewhere around 0.35%. Now, the reason that this is so controversial is that the risk of VTE must be considered against the risk of having a postoperative compressive hematoma. Glotzbecker et al. They performed a systematic review looking at what is the incidence of hematoma reported in the literature. They evaluated a total of 16 studies, 6 of which included patients on anticoagulation. 10 studies did not use any anticoagulation. And they found that the overall incidence of hematoma was 0.2%, and they did not find a significant difference identified in the rate of epidural hematoma. Now, having said that, the concern is still real for postoperative compressive hematomas. If we look at a study by Schroeder et al., this was a multi-center retrospective review looking at patients undergoing cervical spine surgery. It included 16,000 patients from 23 institutions. And again, they found a relatively low rate of hematoma, where it was 0.9%. However, the important part and the reason that there's so much controversy is all patients with a hematoma had a neurologic deficit from the hematoma, and a third of those deficits were persistent at 6 weeks. So, it's understandable why people are hesitant to give people blood thinners after surgery in worrying about having a postoperative hematoma. Now, the ICM looked at answering that question. Does the concern for epidural hematoma influence your choice for VTE prophylaxis after spine surgery? And I'll let you read the answer there. But essentially, they say it's a rare occurrence that epidural hematomas do occur, and that the expert opinion says that it's probably safe to use anticoagulation in non-therapeutic doses. However, the literature does not really support it one way or the other in a definitive manner. So it should be kind of weighed in each individual patient's history. So what are the other ways that we can create VTE prophylaxis? So kind of the gold standards of non-invasive VTE prophylaxis. So early ambulation, sequential compression devices or mechanical compression devices, TED stockings. These are the 3 things that I'm sure all of us practice. The earlier you can get your patients up out of surgery, the sooner you can get them walking. I think that overall decreases your complication rate. And then using these non-invasive measures to try to decrease the risk of VTE is significant. And for patients that are really high risk, placing an IVC filter, having an IVC filter placed preoperatively is certainly a good idea for the right patient. The use of chemoprophylaxis after spine surgery, as I've kind of mentioned, is very variable. There's no real consensus on how we should manage anticoagulation in the perioperative period. This was a study by AO Spine that was published in Global Spine back in 2020. This was a survey where they looked at the anticoagulation use among spine surgeons globally. And they found that most surgeons, 70%, have a routine anticoagulation risk stratification, regardless of where their geographic location was, whether in the United States or not. However, how they treated anticoagulation initiation and cessation, their methodology really varied greatly, just further implementing that there is no consensus as to how we should treat VTE prophylaxis. In 2009, the North American Spine Society tried to publish, or they did publish, an evidence-based clinical guideline for the use of thrombotic therapies in spine surgery. And while they found that there is, some evidence to support the use of anticoagulants, it wasn't definitive enough that they can go ahead and fully recommend it. As Justin talked about with the DMARDs, I think we still have a lot of research to do to prove what the optimum treatment is for these patients after surgery. The next question is for the surgeons out there who do decide to put their patients on chemoprophylaxis. When is it safe to start it? I think this is the other question is, when are we going to use it? What are we going to use? And when can we start it? And so the ICM, again, they propose that it's safe to start chemoprophylaxis anywhere from 24 to 48 hours following elective lumbar fusions. And within 48 hours following patients considered to be higher risk for bleeding. But again, they recommend weighing this against the risk of forming a hematoma postoperatively, and it should be an individual patient decision. This was a study that I came across that I really found interesting. This was looking at venous thromboembolism prophylaxis in elective neurosurgery. It was a survey study looking at board-certified neurosurgeons in the United States. And what they did, they surveyed 370 neurosurgeons who were performing cranial and spine surgery. And they found that 59% of the respondents started their chemoprophylaxis on post-op day 1, 23% on post-op day 2, and 9% on post-op day 3. Now, the interesting part of this for me was that they found that the more senior surgeons tended to hold their anticoagulation longer. And it makes me think, is nothing beats experience. And maybe that's why they're holding anticoagulation longer. And we do have a lack of literature really supporting or defining, what the optimum day to start these medications is. The last bit that I'll talk about here is when do we restart therapeutic treatment? So we had the patients that we were trying to figure out when we could stop their preoperative anticoagulant. And I think, equally important is when can we restart it? What's the optimum time after surgery that we should restart these medications, and when can they be under therapeutic anticoagulation? And really, in my literature review, there was less clear recommendations. The ASRA does discuss when it's safe to start these medications after a spinal, and they typically recommend starting pretty much everything after 24 hours at a minimum, especially the NOACs. And in lower risk patients, you can consider a half dose or a prophylactic dose of these medications prior to giving them therapeutic dosage. However, it's not really been borne out in the spine surgery literature at this point. So, for me, it's patient-specific indications for anticoagulation. I think this is something that, you have to really weigh the risks and the benefits of each individual patient. And this is when consultants are incredibly helpful. And as Dr. Kepler said, try to build a team, build an army around you of good doctors in every specialty. So this is one where I really rely on the cardiologists and the medical doctors at my institution. And lastly, this is one of the few studies I could find where they really looked at the effect of direct oral anticoagulants, or DOACs, around the time of surgery. So they looked at when they stopped the DOAC and when they resumed it after surgery. Their primary endpoint was any abnormal bleeding event that was unexpected. The secondary outcome was looking at VTEs. And they found that in patients that had their DOAC stopped within 24 hours of surgery, they had a significantly increased risk of having a transfusion perioperatively. They had 4 bleeding events that were unexpected, including 1 epidural hematoma. And then they had 4 VTEs, 3 PEs, 1 was a DVT. And all of those patients, they had their DOAC held for greater than 72 hours after surgery. And I think the important thing, or the thing that this adds to the literature, is that there was no difference in bleeding event that correlated to when the DOAC was restarted after surgery. So I think in conclusion, VTE risk around spine surgery remains a concern for postoperative complication. Epidural hematomas, while they're uncommon, can result in significant morbidity. Each patient's medical history and risk factors should be evaluated for risk of perioperative VTE. And really more research is needed to identify the best strategies for dealing with anticoagulation around the time of spine surgery. Thank you.
All right. Well, thanks, guys. 3 great presentations. Certainly a lot more thought and effort and research went into theirs than went into mine. Off the cuff BS. There's a couple questions on the chat. One of which I had a thought about myself, and then someone articulated it as well, which is, what is the monthly cost of Ramosumab? Is that right? Ramosumab to the patient. Do you have any sense of that?
Yeah, so typically if they have Medicare, it's usually Medicare will cover costs up to about $400, I think, per month in actual cost to the patient. If they have Medicare plus private insurance, typically that'll come down to about $200 per month. So it can be a little pricey and maybe potentially cost exclusive for certain patients, but like I said, in my experience so far, which is clearly limited, it's a great way.
Patients are in, South Milwaukee patients are out.
Yeah, exactly.
I mean, that's because that's a lot of money. Like $200 is not a trivial expense, by any stretch of the imagination. And that's one of the things that's sort of been hard hitting about some of the more effective bone building drugs is like they're not cheap. This, especially the monoclonal antibodies, because these companies are trying, probably rightly so, but are trying to claw back their R&D costs.
Yeah, no, 100%. Again, I think like, at least for me, the reason I've liked it is a couple times in I've had 2 different call patients who just bone quality has been less than ideal. And obviously you don't have any choice on operating on those patients or not necessarily, depending on the situation. And so kind of starting them with that peak bone formation within 14 days after has been beneficial. And I think there are different financial strategies that you can use to hopefully kind of offset some of those costs, or at least within our bone health clinic in our institution. So, but yes, it can be exclusive.
That leads to the next question, which I was going to ask anyway, and then you brought it up now, which is that, like, explain like what is the nature of the bone health clinic, particularly like I don't practice in a hospital centric area. It's really like a private practice. Is the bone health a part of a private practice? Is it a hospital based thing? Who staffs it?
So our bone health clinic is actually through within our orthopedic department. So it's a kind of a sub department within that, and so everybody housed within the bone health clinic is actually financially supported by the orthopedic department. And so we have 2 rheumatologists and then a few APPs within that background as well that we can send all of our patients to. They work closely in our clinics. They're right there, easy access. We can get patients in within a week or so. So obviously a pretty a nice resource for us that probably is not typical at a lot of places.
Yeah, it's lucky to have. And one more question for you. In patients who are on Forteo, or you deem the need to have Forteo pre-op, how long do you wait before you do the operation? And do you check it? And do you wait? I mean, like a DEXA scan will lag, right? Like, are you waiting for objective proof that this works, or you're like, okay, like you tick the box, 6 months, let's do the big whack?
Yeah, no, I mean, I think it's obviously going to be situation specific to some extent, right? So depending on how many levels you're doing, if it's a deformity correction, levels of fusion, all that kind of stuff, I think is going to matter or make a difference as far as how aggressive you want to be in trying to treat this and show that you've adequately treated it. But they say, I mean, typically what they say is a 3-month for any kind of anabolic agent that you put on, you want at least a 3-month window of being on that agent before you would operate, ideally. And then for any of the bisphosphonates or anti-osteoclastic drugs, you want to wait at least 6 months. And so I've honestly, there was one patient I had that I tried to wait the full 3 months for on an anabolic agent. They were absolutely miserable after 2 months. And, I just went ahead with surgery. You still outline the risks and all of that kind of thing with the patient. And you do your best that you can, I think, but ideally you're waiting the full 3 months before you go into surgery for any of the anabolics.
I'm always hoping they don't get approved and they don't come back. Okay. Well, thanks for answering the questions, Justin. Actually, let me look at the list. Someone says it's probably true. It's still cheaper than Forteo. Probably true. I'd also like to acknowledge Dr. Ahmad Pirazad, who just gave a shout out from neurosurgeons in Afghanistan. So Justin, in terms of like the various studies on DMARDs, I mean, my take on anything I hear as a recommendation from joint replacement surgeons is always begins with that they're like sort of scared of their shadows. Like this is a group of surgeons who like need something to be afraid of because everything they do turns out so good most of the time that they need like a boogeyman to like keep themselves honest. And so, the biggest study that you had showed that there was really like no difference in infection. And so like, should we take that to heart? Because, embarrassingly, thanks for bringing that up along with my gray beard and being old, that I'm on this paper that like had this gutless, no recommendation, and so we don't really have anything to go on. So like, what's your gut?
Yeah, I think that's a great question. I think that number one, I would kind of defer back to the rheumatologist for a case-by-case example and treating these patients individually.
And his sister is taking referrals.
If that's,
his sister is taking
yeah,
referrals.
exactly. Anyone in Pittsburgh needs to see a rheumatologist. No, but I think in the absence of that, I would probably choose to continue these patients on their medications. It seems like, although there's not a ton of literature, there's a great deal of heterogeneity and the spectrum of disease is variable. There doesn't seem to be good evidence to point me away from continuing the medication. And then also kind of to your point about the joint surgeons, an infection in joint surgery is not that it's not a big deal in spine surgery, but it's more catastrophic than an infection in spine surgery, assuming that you're able to get to it in time and it doesn't cause a neurologic impairment. So for all those reasons, if I didn't have a rheumatologist to kind of help coach me through the process for this individual patient, I would be inclined to just continue them on their meds.
And that's sort of like been my approach, again, but like kind of blind. And that's always like an anxiety provoking situation in general. And like, loading the boat helps as you do it more times, with all the, respect and deference to your sister. Like sometimes you realize they don't really know either. And they they have the same set of data you do. Yeah. You're no dummy if you got into orthopedic surgery residency, and so you can evaluate those same papers. But I don't think there's a good answer out there.
Well, and also I just want to make a point that I highlighted a couple of the studies. Rheumatoid flares are a big deal, and going on oral high-dose steroid medications probably increases the risk of infection. And so in an effort to avoid that, I think is another reason to continue the DMARD therapy at the time of surgery if you're looking for something to push you in one direction or another.
Right, because at the end of the day, it's true. At the end of the day, like you may not be the one that orders like the high-dose steroid protocol when people have a flare, but like you're the one holding the bag if like all the metal's got to come out because they get an infection. So
exactly.
Taken. Make sure there's nothing else on here. No. So interestingly, I want to make a little comment about the anticoagulation. Is that we have it's not published. It's sort of pre-full analysis, and we're still waiting for a complete data set. But we have data from our institution that compares, and it's over thousands of patients. So this is over. We established our anticoagulation protocols after routine surgery in patients who don't have a reason to be aggressively anticoagulated in my first couple of years in practice. So it's almost 10 years old. And so between the Department of Neurosurgery, which is at Jefferson led by Harrop, and our Department of Orthopedic Spine Surgery group, we have 8,000 or 9,000 patients in this protocol that we have data on. And the difference between the two groups is only 1 day of anticoagulation at lumbar levels, 2 days at cord levels, where the neurosurgeons start anticoagulation every single patient on day 0. in that group. We started on either day 1 for a non-cord level or day 2 for cord level. Again, as you saw, based on really nothing in terms of evidence. And there's substantial differences in terms of the likelihood of take back for hematoma or seroma within the first day or two. And there's significant differences in terms of thromboembolic phenomenon, DVT and PE. Now, there's not differences in terms of death, but I think this leads to maybe what John was suggesting, which is what spine surgeons who've been around the block remember is taking patients back. What spine surgeons who've been around the block probably don't remember is a non-significant difference in DVT or PE that doesn't affect outcome and is, maybe like something that's a screening problem as much as anything. And so, I think that higher level data or higher quality data as you get into the weeds on this probably will show differences. It's just that number is not out there. And so we're trying to put our experience together and trying to get a second sort of control group, if you will, that doesn't have any DVT prophylaxis to see if that trend bears out. But within just a difference of a day or two in an institution that has relatively aggressive anticoagulation protocols, meaning we use it for everybody who doesn't have a strong reason not to have it, we've shown differences in the two things that everybody cares about, which is DVT PE and hematoma takebacks. So I think there's a story left to be told there. I can't claim to know what the answer is going to be and where it's going to come out, but I think it's hopefully one day NAS will publish a paper that is not as gutless as a paper that they showed my name attached to, and which means that they'll be able to say something real. Is there any other questions from the wider audience? There's nothing else on the chat, and we're just a little bit past the time limit, but we can entertain a question if someone wants to jump on. Otherwise, we will call it, and we'll look for you guys next time. I can't believe there's no one from Texas back who made it onto this whole talk. That's like a new record. Anyone? All right, that's it. Guys, let's call it. Thanks.
You guys are great. Sorry, I've been watching you guys, and this was amazingly valuable. I mean, we're going to have all of our fellows watch this. This is really an instructional course lecture for ortho and neurosurgeons alike. Thank you. One question. So this goes to high-risk VTE patients. Let's just say people who have not been therapeutic anticoagulated, but they're clearly high risk. What is your one drug of choice that you'll give them afterwards for anticoagulation? Let's say SCI patients, tumor patients, the known high-risk patients. What is the drug that you put them on?
So, I think the two choices looking at the literature are either Lovenox or sub-Q heparin. I would tend to do sub-Q heparin. I think that's the kind of standard that we use at Jefferson, unless our trauma surgeons, non-orthopedic trauma surgeons, push for Lovenox. We tend to have a policy in our institution of prophylactic Lovenox for each of these patients that we continue after surgery. I don't know if Chris, if you have anything else to add to that, but that's what I would say is probably the standard.
Yeah, I wish we had the guts to be more aggressive, because I think there probably is room there. Lovenox in particular, which is what is a preference of our patients in the surgical ICU, their team's preference, is the only thing that's been sort of shown to have increased likelihood of wound breakdown, wound drainage. And so everybody gets a little skittish about that. Most of the time that still probably is relatively innocent, but we don't have the guts to do anything more, basically. Dr. Chapman, what's your take on it?
Yeah, I really, first of all, want to commend Rothman and all you guys for having heavily contributed to the literature in a structured fashion. So I want to really applaud you for that. And again, I've just had tragedies when people stopped their Lovenox at the 2-week mark after they left rehab, and we didn't put them on an oral after that. And then I get a message they had a PE into the ER to pee.
No one dies from a take back for a seroma or hematoma. It's a bummer, but usually it's neurologically innocent. People die from PEs. And so that is kind of my bias too, is that, if you're trying to avoid a complication, you try to avoid the catastrophic complication. but it's an incomplete body of literature.
And our federal government does not pay for oral anticoagulants after about a 2 to 3 week period. So when they're discharged from rehab, unless you want to give them aspirin, which may be fine, they're not going to pay for the more expensive oral anticoagulant. So this is a true hole, and I think unless they have a documented VTE event or history, so this is really problematic. So yeah, but again, thank you for the session, and thank you for all you've done in the literature, Chris and colleagues at Rothman. Really awesome work, awesome contribution.
All right, thanks so much, Dr. Chapman. All right, we are going to call it there. Tune in next time for Seattle Sounds Foundation. It's always fun. Take care, guys.
Okay, you take care. Bye-bye.